This conference will now be recorded.
Hello and welcome all of you. I'm Dr. Rashmi Patil here. Is my slide visible to all of you and my voice is clear?
Yes, ma'am.
Yes, it
Okay,
is.
thank you so much. So thank you for joining in. So what we are going to do today is have an introductory session. A few of us are aware about the examination pattern and other things. Few of us are new who have recently passed from the exam and they are ready to take up the Part 3 MRCOG in the upcoming exams. So I welcome all of you for this introductory session. The purpose of this introductory session is to brief you all about what the exam pattern is, and most of us are already aware, but I'll be telling you a few key points about what it is. So congratulations for all the Part 2 candidates who have cleared and who have joined us here. And from here onwards, I would say that there is no way that you're going to look back, because it's the final step that you're going to take up, and after doing this step you'll be getting your MRCOG degree and the convocation follows. So what exactly is Part 3 about? So first thing is to sit for the examination. There is an eligibility. All of you, yes, recently now I got few messages saying that the AOT was also approved today. So after passing out the Part 2 MRCOG exam, the AOT has to be assessed. So all of you have got your AOT assessed now. Officially, the RCOG website, it keeps updating about all the examination things, and we'll also be posting in the free group as well as in the course group regarding all the updates from the RCOG exam and the bookings, everything. I'll be helping you people with that. Now, this is the older RCOG website where we got the patient the section where we get most of the information about the patient related communication, that is in form of PILs. If you look into the new website, all the websites, it's been upgraded now, so the PILs are easily available. They are the most important things in the Part 3, because communication is all that matters, along with the applied clinical knowledge. Yes, as a backup it is a must, because you should know what you're going to explain that to your role players. It is a clinical assessment of your knowledge, of the skills, your attitude and the competencies put together. Now, passing Part 3 will give you the MRCOG degree, and you get yourself assessed, and you will become eligible to get the higher trainings as ST6 and ST7 level as well. So initially they may take you in the hospital at ST1, ST2 level, sometimes ST3, depending upon the competency, but later on they promote and you will be eligible to apply for the training as well. Now, Part 3 MRCOG, it's a clinical assessment. It consists of the 14 tasks in a circuit, and each task is based upon 14 modules. So it consists of teaching, core surgical skills, the post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, the postpartum problems, gynecological problems, subfertility, sexual and reproductive health, early pregnancy care, gynecological oncology, urogynecology, and the pelvic floor problems. So what we are doing in the course is the major modules. For example, the antenatal care, the maternal medicine, and the gynecological problems, they have many stations, and therefore we'll be dividing those modules into two parts. And we'll be taking at least like the 15 sessions are going to be covered as a part of the regular course. Now, in the exam, excuse me, there are 14 stations. You will be getting 2 minutes to read the instructions, and 10 minutes will be for the performance. When I gave my exam in November 2019 in Chennai, we had a face-to-face examination. All the 14 stations were performed together. There was no break. Once the bell started, it was a time to read the station. There was 2 minutes of reading time, followed by 10 minutes of performance. And we moved to the next task, and 2 minutes of reading time plus 10 minutes of performance. But the only thing what is different is the Osler system, because Osler system is an online exam where they had given a break. So what they did is, after 7 stations, they had given them a break and later on continued with the further 7 stations. And if ever there was some problem with some communication or network issues, some stations had to be rerun. So more likely that they want RCOG, people want face-to-face examination to be started at the earliest, provided all the situation, everything permits. But till now, non-UK candidates had all given the OSLA system, that is the online examination. What are the tasks that we are going to face? One is a simulated patient task where your examiner will be sitting and there the role player are sitting. You are talking to only role player. The clinical examiner does not interrupt. Uh, they do not question you. There is no interaction at all. When it comes to a simulated patient task with a lay examiner, there are two people sitting over there who are going to examine you, plus there is a role player. So clinical examiner is a person who has background knowledge about obs and gynae. So they are the members. The lay examiner could be a non-medical person. They are just sitting there and judging you the way you're going to communicate with the role player and how you're going to give the information or perform the task. Like it could be breaking bad news or angry role player, how you're dealing with the emotions. It could be sad or crying role player as well. They are there not to judge your knowledge. They are sitting there and judging you as a person, as a doctor, how you're treating a patient. The role player will also be judging you simultaneously, but they have different set. Plus, in the end, the role players again, they have a question whether they want to see this doctor or not. So if they are happy with your consultation, they may uh, put a yes for that. So it is very important for a lay examiner stations, because this is a maximum scoring station over there. Three people are going to sit there and judge you. Where a structured discussion is there, it's a one-to-one interaction with your clinical examiner. It is like a viva exam that we give. So there is a scenario and we discuss that scenario with the examiners. It could be labor ward prioritization, the gynae ward prioritization, discussion of some placenta previa with Jehovah's Witness and previous cesarean. She has come at 18 weeks and later on 32 weeks. So the scenarios could be different. But here only one person is sitting and they are going to assess you. So amongst the three type of task that you're going to get, maximum scoring station are the lay examiner stations. It could be like somewhere like four stations or sometimes five, they could be there. Structured discussion could be four or five again. Remaining will be a simulated patient task with a clinical examiner and the role player. So these three tasks are, this is how it is organized in the exam. When it was a face-to-face, there were small cubicles kind of arrangement which was done. So for example, I started with my the number 3 during my exam. So I went and stood beside the cubicle 3. The bell rang and I read the instruction. I just entered that cubicle, sat down on the table. There were the instructions also on the table. So if I wanted some reference, I could even have a look at them. So if possible, then if I want to refer something also, it is there. And you get a notepad and a pencil to write down your key points or draw a diagram, explain it to your role player or your junior if you want to communicate something, or you can write down your key points and make some small notes when you're reading your task outside as well. So most of the time you may not get time to even have a look at the paper or something, because you're communicating directly with your role play over there. Sometimes when you're explaining investigations, yes, that time you can say, these are the investigations in front of me, and I confirm your name, age, date of birth, and NHS number, the details, everything, it belongs to you. And the investigation says 1, 2, 3, 4. So you can use that, right? It is there in front of you. You can use that also and you can communicate. In the online exam, there were PDFs which were like you're supposed to click them, it opens up, you're reading them. But once the time is up, the role player appears in front of you. The PDF it minimizes. And if you want, you can click on the PDF as well. But they could make out, like if the clinical examiner or the role players, they are looking into your eyes, you're not maintaining an eye contact and speaking to them, but just reading some lines which are written over there. So that shouldn't happen. So what I would suggest is practicing reading fast is important, and the practice books are going to help us with that. So reading a task in 2 minutes assimilating everything, and then performing the task. So with the confidence, that is very important. So these kind of approach, everything will be teaching in the course about how to approach each module, how to approach each station, how to deal with your examiner, your role players, and especially when there are lay examiner stations. What are they going to judge you? Especially the modules which are there, they are divided into all the domains. So each station may or may not have all the domains. It's not compulsory. These domains are patient safety, the communication with your patient or the relatives, the communication with your colleagues. It's a kind of a multidisciplinary or a multi-professional approach that you have. Information gathering and the applied clinical knowledge. So what we are going to do here, the main focus RCOJ does is on the patient safety points and the communication with the patient and all. This is really important because they should know that you're a safe doctor. And like when you come to UK or you're practicing with an MRCOG degree anywhere in the world also, you are going to practice the safe medicine. Your approach to the role player or your patient is going to be different. You will be more empathetic in your approach. You know how to gather everything in the short period of time and communicate that thing effectively as well. So all these things, so MRCOG is not only going to give you a degree, the approach to the patient itself is completely different, I would say. And it's totally different from your part 2 exam because part 2 1 everything they have judged your knowledge. So there is no doubt about that. The fact that you're there giving an exam for the part 3, it means you have already the knowledge, everything is judged. But the same knowledge has to be applied now. So it is not like the knowledge is not important for your part 3. It is very important. You should know the algorithms, you should know the management points, and you should be updated with the recent guidelines and the changes that are being made, because that is how you're going to communicate in a patient friendly language. So speaking about the simulated patient task, it could have all the 5 domains as well: the safety, communication with your patient or the colleagues, information gathering, applied clinical knowledge, structured discussion. There is no role player, so you won't be having your communication with your role player. Scoring system, they give it as 0, 1, and 2, and they do have certain key points where they are checking you upon, and you're mentioning all those asterisk points or the important points which are essential to clear the station. So if you're not mentioning them, you may have told 100 points or something, but if I've not mentioned that one key point which is important for that particular station, then it could affect your entire station as well, that particular domain. 2 is going to be a pass, 1 is going to be a borderline, and 0 means fail. So our target is getting 2 by 2 in all the domains. Why is that important? Because we will be training you how to communicate with your patient and the relatives or something. So once you're effectively communicating, definitely you'll be getting your 2 by 2 over there. Information gathering also, we are training them that they have to be quick. Within 2 to 3 minutes maximum, they have to gather the relevant information. Initially, we'll be giving you a bigger template because it is going to help you practice those sentences. You should know what exactly they mean. But as and when you're submitting the task in the course Telegram groups, you will understand that how to cut short your sentences. We'll be teaching about all these things, that information gathering and the basic, the introduction agenda, everything has to get over within 4 to 5 minutes. From the 5th minute, it is going to be your management. So clinical management, your clinical governance points, everything has to come in those particular 5 minutes, and especially 4 minutes you can target. From the exam point of view, your performance will be fruitful 9 minutes. 1 minute extra you have to keep, because sometimes the role player may take some extra time to ask the concerns or something like that, but you're not going to ward off those sentences. You have to address them. That is very important. So how to perform the station, how to do the HOPI, which is targeted. Never forget that if she's a pregnant lady, you're not asking her pregnancy symptoms. For example, it's an early pregnancy care. And just one sentence like, do you feel sick, any pain or bleeding down below that you have experienced, or how is your pregnancy going so far? This is very important because you're addressing the HOPA of a pregnancy. And you can also simultaneously, for maternal medicine station, you're also asking regarding epilepsy or something. So when did can you tell me more about your condition? I wouldn't tell that as a disease, because they have been living with that particular condition, and they are not like sick or something. Their condition would have been stabilized, and more commonly they are visiting their specialist, they are under routine follow-up, they are on certain set of medication. So I'll be teaching you regarding how to clearly approach a maternal medicine station, how to do the preconception counseling, how to deal with the pregnancy with the medical problems. So all these HOPIs, how to gather, each and every station will be emphasizing on these points. Information gathering, I'll be dealing with that in the further slides. Signposting is one important thing. For example, if there is a person and you have to break the bad news, so you are preparing that person that you're going to give some difficult news or a bad news. So signposting usually involves like, you are telling, I can see that you're alone today, but do you want somebody to be there with you, because I have a lot of information to discuss. Or you can say that there are some concerns in your scan, there are some concerns in your report, something like this, a sentence which is going to warn them that okay, something is going to be abnormal, or something is going to be difficult news or a kind of a bad news. So they start preparing themselves to accept that news. The second thing is, I'm sorry that your report has some concerns. When you're saying like this is the second signposting with what you're doing them. You're preparing them stepwise to receive that information, right? And the catch is there are certain things where confidentiality matters a lot, especially in stations like fertility. So you cannot openly discuss that, somebody has to be there with you or something. You can say that there are, I can see that you're alone today, but I want to discuss these reports with you, maintaining confidentiality, and with your permission, we can involve your partner or something. So when you're telling these kind of sentences, the person knows, okay, there is something problem, but yes, the doctor wants to discuss them with me, and with my permission, they want to involve the other people, otherwise not. So until and it's like, other people's safety is in danger. So this kind of signposting where you're preparing a person to receive some difficult news or a bad news, these stations are very important, where the lay examiners are also sitting. They want to know how you communicate with your role player. So it's very important for us to make it a strong point that lay examiners, everybody, the role players, clinical examiners, the lay examiners, everybody, they understand that yes, you are communicating effectively to your role player, and your role player connects with you. So this is really important. We'll train you through all these tasks as well. Now, summarization of the case. This may or may not be required. I never summarized in my exam. I always felt like, I will lose some time, or because in the preparation or when you're performing a task, I was so like, worried whether I'll be able to finish my task in time or not. And I used to always practice with a timer. I had to finish my task within like 9 minutes. So whenever I was doing with my role player, my study buddy, she was there. So whenever I was practicing with her, also we used to set some time. And whenever I used to do alone, practice in front of a mirror or in front of my daughter, something. So I used to always like set a timer. I wanted to know that if I'm speaking fast, also it should be clear, and the role player understand your sentences. That is important. Second thing is, whenever there is some difficult news or something, I knew how to modulate my voice. So if I'm saying that, your report shows that it has cancer, it looks a little harsh to the role player. But if I'm saying the same sentence that, I'm so sorry, there are some concerns, and I've confirmed your details on this report, your name, age, and NHS number, and it belongs to you. I'm sorry to be the bearer of this news, but it shows that the tissue that we had tested, it is showing sinister changes, and it says that there is cancer of the lining of womb. You take a pause. So my voice modulation is there. I am trying to bring down my voice, but I'm not cutting down on the speed, but I'm changing my voice tone. I'm trying to connect. I'll take a pause. Are you with me? So these kind of modulations or these kind of the changes that is required. So we will be training you, we'll be listening to your voice submissions, the recordings that you submit. We'll be listening to all of them when you're practicing the books in the Telegram course groups also, and constantly we are giving feedback. I used to train my juniors like, no, one more tone lower. You have to do this. You have to be more empathetic. That change of voice is a must. And at last, like she was like, sorry, ma'am. I was like, yes, this is the tone that I want in your exam. You know, the tone with which you felt a kind of a little guilt and you were like, sorry, ma'am, yes, this is the tone. Speak to your role player. If all stations also, if you're performing in a low tone or something, that should be fine because as long as they are hearing you correctly, they are understanding what you're saying, and your communication is good. So that is what they are looking for. It's not like a loud voice or something will only be heard. In face to face, yes, they are sitting right in front of you. And when it is an online exam, all my juniors, everybody, they used to wear the speakers. We had the rehearsal sessions and we had the mock exams as well. The circuits were conducted. So I used to guide them, okay, this is not the right place because background is not correct. You have to shift your place. The light is falling from behind. Make sure it comes on the face. Your, the color combination, what they're wearing. So it shouldn't be very bright and catchy to the role players and the speaker as well, because we used to test all the speakers like which is better, the voice one, this is correct, this is clearly heard or not, which speaker is better for the exam. Everything we have done. So it is a must that we have to be prepared until RCOG announces whether it is an online exam or a face-to-face exam. We have to be prepared for both of them. So we'll get to know in like a couple of weeks which are coming ahead. So they are going to be very clear. We'll be training you for both the patterns. Like in case if it is going to be like this, what we are supposed to do. In case if it is going to be online, what we are supposed to say. So I'll be giving you all the lines where you have to practice them. Examination in presence of a chaperone with the consent. So these are required especially when you're doing a face-to-face exam. When you're doing an online exam, you can just say that I'm sorry, I'm not be able to offer you an examination, but if the need arises, we'll be having a face-to-face consultation. If you say that much, it will hardly take few seconds, and then you can close that point. Investigations, when you're telling, it is very essential that the confirmation of the details is important of the role player, the name, age, NHS number, and date of birth on the investigation report. And when you're telling that investigation, you should know like what it means, whether this is a cancer, this is an IUD, or what kind of investigation you're sharing with her. Depending on that, you have to signpost and then share. But if it is just like, hemoglobin is 11, your thyroid level is 2.5, these things you can speak in a normal tone. Or I'm going to check your hemoglobin. If you're asking for some investigation, please justify, like, to rule out infection, to check your blood levels, urine test to rule out infection. So whatever you're giving them the investigation that you're going to recommend for them, you have to justify why you're getting them done. Okay. So either there are reports which are available that you need to discuss, or there are tests that you're going to offer them with justification that why you want to advise them that investigation. Once all these points are done, so your history taking is done, the examination part is done, the investigation parts or something that you want to offer, that is done. The management point, it depends on two things. One is your clinical management. The second thing is clinical governance. I used to always practice putting this skeleton in my mind of um, the clinical management, what I'm going to say, the clinical governance, what I'm going to say. If clinical management, is it something like expectant or it is a conservative kind? Is it a medical line? Is it a surgical line? If it is surgical, is it going to be a conservative surgery, a definitive surgery, a laparoscopy, or a laparotomy? Everything used to flash in front of my eyes. So I knew exactly what I'm speaking. I had put that kind of an algorithm in my mind. Then comes your clinical governance points, where I'll be giving a slide composing of all the clinical governance that you need to practice. And 1, 2, 3, 4, 5, 6, 7, it should flash in front of your eyes. The slide should flash in front of your eyes when you're going to end your station. And all the D's are important over there: your documentation, your debriefing, and your duty of candor that you're performing, any DATX that has to be released, then whether it is going to be a discussion of the case as well with your colleagues, a discharge summary that you're providing. So everything is important over there. So the clinical governance, it is essential part of your station. Not everything applies to all station, but basic things like, documenting or having a discussion, debriefing, these could be applicable to most of your stations. About investigations also, you have to think like, okay, these are my blood investigation, these are my urine investigation, these are my imaging studies, these are going to be the scan, this is going to be a CT scan or an MRI or any special test like 2D echo, HbA1c, anything that is required. So always have that picture in your mind that if I'm going to start speaking, what should be in my mind when I'm discussing these things with my role player. Does this apply? No, I'm not going to speak on this. Does this apply? Yes, I have to include this in my discussion. So you are like, for example, there is an ovarian tumor that she has come with, ovarian cyst. Your CT scan, C125, everything that has to flash in front of your eyes. So maybe like urine analysis may not be important there. So you have to discuss your CT scan and the CA125 correlations. So whatever investigation you are going to offer, please justify that. That is really important. Now, I always tell my students that make it a habit, make it a practice that when you start your clinical management, always begin with an MDT. Remember that you are an ST5 level. They do not expect you to manage everything on earth. It is beyond the capacity of an ST5 to manage a spina bifida or something like, pulmonary hypertension. All these complicated cases and all, they are not made for you. But why are you discussing? Because you should know your boundaries. You should involve an MDT. So what I tell all my juniors is, the moment you start with the management discussion, your care will be under a team of specialists, which will include 1, 2, 3, 4, 5, 6. It will be your consultant, excuse me. It will be your cardiologist or the heart doctor. It will be the neurologist or the brain doctor. It could be the nephrologist or the kidney doctor. It could be a pediatrician or your baby doctor. You start telling your entire team, a specialist nurse to take care of you, then a counselor for your help and support. All these people are important. So think for a second that, who are the people that I would like to involve in my care plan. So you can say that this is going to be a shared care plan for her, and all the team with that effort and involving her caregivers, you are aiming for a safe outcome for her. This is what, like, you are there to support her in any situation. So me and my team of specialists, we are there to take care of you and support you. So you have to tell regarding this MDT in the beginning. This is going to give you 2 of top 2 because your communication with your colleague, that point you have marked. If you say that I'm going to do all these tests for you, I will be doing the scan, I will only take care of you without involving anybody, without putting her in a consultant-led care, without involving the specialist for her care plan, you are changing all the medication, teratogenic, you are removing, putting her to safe medication. But what if that is the only medication that her condition is stabilized on? And taking out that medication would make her throw another fit. So it becomes very important that the decision making, anything, there is no harm if you involve a consultant in any of the decision making process. And if the role play asks you some question where you don't know the answer, you can say that right now I'm not sure, but is it okay if I ask my consultant or go through some literature and I get back to you on this? If you say that, if you admit that you don't know also, is okay, because they are not expecting you to be 100% full of knowledge and you are telling and answering each and every question that they're asking. But if you don't know something, at least you are not lying on that, you are not telling some wrong information, you are not compromising the patient's safety. So your applied clinical knowledge domain may get even a borderline also, but your safety is 2 out of 2 there. You're not giving some wrong information. Never compromise your patient safety with your applied clinical knowledge. There are students of mine who have crossed like 70 plus, but honestly, their applied clinical knowledge did not reach up to expected standard, but still they cleared the exam with 70 plus percentage. So why? Because they were excellent in other domains. Maybe that day, that station, they did not speak something which was there for management or something like that, but it doesn't mean that they were lacking on knowledge. Maybe they didn't get that much time to explain things, but it didn't mean that they didn't clear the exam. They got 70 plus. So what does this mean? Like, you can compromise the applied clinical knowledge to a certain extent. I wouldn't say fully, but certain extent. If you don't know anything, please admit that and take the station forward. If you know something, put the skeleton in the beginning, that this ectopic she has come. Usually there are things like conservative treatment where we just wait and watch, and there are medicines to dissolve the pregnancy. But I'm afraid, because the tube has burst open in your tummy, I'll be not able to offer you these two options. So what remains with us is a surgical option. But I can see that your condition is stable at present. So we'll have a discussion with the consultant, and probably we'll be offering you a keyhole surgery. So this is how you're taking that station. You are telling your examiner that okay, ectopic management is 1, 2, 3, but what suits her the best is the third option. In that, what suits her the best? She's stable, then go for laparoscopy. She's unstable, laparotomy. Clear cut management, no doubts about that. So it is very essential that your applied clinical knowledge, you're showing it in a chart in the beginning to your role player and your examiner. These things are there. In my exam also, I just told her that there was a prolapse, and there are options like we do exercises, and we have like weight control measures and other things and all, and we do have some supportive measures like pessaries. There are surgical options. She was like, no, 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 I don't want surgery. Can you tell me about pessary? The role player herself, she told me, like she ruled out one option completely. She said, like, I am not for surgery. Please tell me about pessary. She guided me, and yes, my management was concise. But what did I tell my examiner and my role player? This was the key. Like, all these things are there. But what do you want me to discuss first? What are your thoughts? What I like, have you thought anything for yourself? She had already preoccupied mind that she doesn't want surgery at any cost. So it was clear cut for me. I had to just explain some general measures, and she wanted more about pessary. So it was very essential that I tell her about what pessary, what kind, what precautions, how it is done when you want to change. All this, my management was cut short by the role player herself. So it becomes very essential that when you're discussing the management, just put some key points over there, put a skeleton, and tell these things are there. Is there anything specific that you want me to discuss? She would say, doctor, please, I do not want any medicine, something, please do surgery for me and take out my tube. I don't want any medicines because last time they gave and it burst open and I lost my tube. Something she will tell you. So if any weird option that she's choosing, or there are some things in the station that she's clear cut telling, no, I don't want this. There could be some reason behind. You can just ask, like, I can see that this point was disturbing you. So is there any particular reason? She would say, doctor, my sister had this, and otherwise my friend had this, and I've seen them suffering. Some story she will tell. Or if she would say, no, doctor, I'm not keen on medicines and all, please take out my tubes. Something she would tell. So it is very essential that you put up the MDT approach, you put up a skeleton of your management, and then explain everything. You have good 4 minutes to cover all these things. Keep a spare minute extra because role players sometimes may take some longer time. Not all role players are the same. So they may speak slow, they may speak fast. It doesn't mean that you make them like hurry up, please tell fast. My time is running. No, allow them to speak. They may be doing for a purpose as well. The clinical governance points, again, they are very essential that you'll be doing. As I said, without completing the clinical governance points, you won't be like doing justice to that particular station. So it is very important that you're discussing these points. Yeah, did my slide change? Okay. Next is about the patient information leaflets, support groups, writing back to the GP, an MDT approach again if required, then writing back again to the an appointment with the consultant. So these are the next steps. So what I used to do is in the beginning, I would say like, if the station is going to be calm, like just I have to have an OVD discussion. I used to tell her in the beginning that I'll give you certain leaflets and support groups and write back to the GP in the end with your permission. And if required, again, we can have a consultant discussion as well. Because I was thinking maybe I may not get time in the end, so I used to tell this off like within few seconds and finish it off. So it becomes essential that you are explaining your points. I think there is some connection is there. I'll be joining back my PPT again. So it is very essential that you are explaining your points and giving information leaflets or support groups and writing back to the GP everything. If you want, you can tell in the beginning. If you want, you can tell towards the end also. So that shouldn't matter much. About 24/7 hospital emergency contact numbers, you can give them. So especially like stations where you're doing some medical line of management and you want her to be alert, you can offer her admission if she doesn't have anybody to take care of her, or she is not ready for a follow-up kind of a person who is there. So you can offer admission at that point as well. And otherwise, what you can do is when you're giving or sending the patient back home, it is always advisable that you give some 24/7 emergency numbers also. So that is also important. Yeah, I'll just join my presentation. Okay, so giving an emergency numbers. So you can just say 24/7 emergency numbers, and you can give some support groups. Talking to them can make them feel better. They can, for example, there is a Down syndrome baby or something. So you can just connect them with the Down syndrome association, where she can talk to the mothers who have Down's babies, and they can share their experience about how to raise a Down's baby and all. So they can give you more information also about their personal experience. So these kind of support groups, they are common in UK. If you do not remember any support group also, even if you say that I'll connect with you with the support group also, that should be sufficient. You don't have to sit and memorize all like 60, 70 support groups in your entire MRCOG part 3. If you remember, well and good, you can just say it off. If you do not remember, don't worry, that is still acceptable. At least you'll be connecting them with the support group. So that is important. Next is about a follow-up care plan. For example, if she has been operated and you're explaining about the discharge summary, you're telling her about red flag signs. Red flag signs means if she feels unwell, or she is, for example, she could have some pain at the site, if she's vomiting, if there is some bleeding down below, some concerns which she has, or fever, foul smell discharge. These are the red flag signs which should warn the patient. So when you're sending the patient after a surgery or something, it is essential that you warn her that, if you feel that feverish or a discharge down below, or if you feel unwell, please get back to us immediately, and we'll be giving you some hospital contact numbers as well. So these are the red flag signs that you're telling, and a follow-up care plan with your discharge summary thoroughly. The GP, everybody, they'll be knowing like what to do for her. Plus, she can have a discussion again with the histopath report. So these are essential for the follow-up visit. And if you're telling regarding another appointment with a consultant, if it is required, that also you can do. Now, exam pattern, the Osler system, 14 stations were there where everybody were like online, they were coming together. Some glitches were there where internet connection between examiner, the role player, the candidate, sometimes lay examiner, everybody has to be there, right? Even if one person internet was a problem, it was raising an issue. And again, candidates, sometimes they were asked to redo the stations as well. They have done 2 station, 1 station, sometimes 5 stations also. But anything beyond that, they had just cancelled that exam, excuse me. So everything has its plus and minus. Sitting at home giving an exam, that is also a kind of an home birth station, I would say. So you're there in the cozy environment of your home, and all your surroundings are familiar. So sitting at home and giving exam is a different experience. Your travel thing, your expenditures, everything are saved. But when you're doing a face-to-face examination, it is a direct sitting in front of your role play. You're communicating there. Everything that you're explaining, it is easily understood by them. They are right in front of you, right? These glitches of internet, everything won't be there. I would suggest whatever is the approach, it should be your best performance. The beginning should be the best, the ending should be the best, and in between, whatever you're speaking, your approach, you're explaining, everything has to be best. It is not like, you're just for the sake of performance you're doing. So I'll be preparing you for the approach to the module as such. Even if you get a new station, you should know what you're supposed to do in that module. Nothing to be worried, because majority of them you're doing that in your day-to-day practice, you're doing in your clinical experience. Just you should know how to approach each station smartly. That is important. And how to pass the station by giving those good sentences that you're going to speak, and having a smart approach. Yeah, sorry for my bad voice. So your hard work, yes, it is important. Dedication is important. Efforts are important. Along with that, we are there to help you. So we are constantly pushing our course group people to submit their tasks. It's been just a month. They are already completing their 2 books. So I want all of you to complete all the practice books that we are going to do in our Telegram group. There are the Warriors group where we are constantly solving all the recalls station, the important stations as well. And we do have the templates group. So the written templates, everything have been put up. Apart from that, we do have the website. So I'll be all the people who have joined our course, so they know there is a vast collection. There is a lot of PDFs, more than 200 plus templates, everything we have arranged module wise. I have put up the guideline summaries as well. And I'm adding on all the important PILs also along with that. That particular station, if you're opening, you'll be getting extra 3-4 PILs along with that. So you know what material to study, everything you'll be getting in one place. And like, okay, this thing, if I study that much is enough. And there are 500 plus voice recordings which are being arranged module wise, and we are putting up all the books as well now. So these recordings will prepare you from day one itself. What you have to do, just early pregnancy, if you're the next session is there, open up the templates, open up the voice recording, read them, listen to them, and you're ready for that. All the materials, everything are going to be shared. So you just have to keep revising those things. Listening is also important. When you listen to others voice submission also, like, okay, what has to be done or what not should be done. So your approach to one particular station also, it varies. And we'll be telling you, okay, this part, okay, this is a kind of approach, but what they expect in exam is this approach. So we'll be telling you all these things, and the best solution that you have is be confident, be smart in your approach. Your knowledge from the part 2, that should be there. It has to be brushed up, and that has to be applied for your part 3. So practice with a study partner, where if you're having a strict study partner, it is very important. Will there be a case discussion? No, dear. Today there is no case discussion. So I'm just briefing about the introductory session as well. We're not having a case discussion today, dear. I'll be planning it in a few more days. So practicing with a study partner is important. It could be your study buddy who is preparing for part 3. It could be a family member who will act as a role player. Your friends who are non-medicos. Your patients are the best role players. In the OPD, just sit for 10 minutes. My students have even attended their OPDs, their surgeries, everything, even the day before exam. Some were on, including me, I have done everything in my postpartum period. So I have given my part 2, 3, I've cleared them in my postpartum period with the baby. So some had taken a break of 15 days, some had taken a break of 1 month, some had not taken a break because they said, like, work brings down my stress levels, And there also I'm practicing with my patients. I said, like, why not? They are the best role players. 10 minutes you're discussing everything in front of your patient. Your OPD time is also saved. Plus you're effectively communicating with your patient. What else do they want? Your juniors who are there, the nurses, your junior medical students or somebody who is there, perform your teaching station with them. Just catch hold of them. Come, I'll teach you today forceps. And you just catch hold of them, and within 10 minutes, whatever you want, you teach them. Your nursing staff is there. They want to know about CTG. Just call them, take out a strip, start explaining them. 10 minutes and that is done. So they are the best role players for you people. Please make use of all the resources around you. The mirror also. I used to watch my expression when I'm telling something. I didn't want my face to look weird or something. So I always maintain calmness on my face whenever I'm discussing anything with my patient also. Should be very calm. They could be angry, they could be crying, they could be, frustrated kind of role plays, any person. But you have to be calm. That control should be there. That they are angry and that you shouldn't reflect back that anger. So if you look into the mirror when you're explaining certain things, you will also know that how your face is behaving. So you can practice with the mirror as well. And we mentors, me and Dr. Geetika, we also take one-to-one stations. So more so towards the exam when they are prepared, we do take circuits. Like for example, they students do tell me, like, combine 2-3 modules and give me 5 stations or 7 stations. So either they are 5, 7, or sometimes 10, or they take multiple circuits. So there are candidates of mine who have taken, like, 8 complete circuits before exam as well. So every 3 days they used to perform one circuit. So complete different set of circuits, which the total different stations we had to prepare. So it was like complete 8 circuits also they have done. So towards the exam, practicing mocks becomes important because your stamina will be building up and you'll be knowing how to approach a station within that particular 2 minutes. Your mental exhaustion shouldn't be there. So when I was entering the station, I was like ready. These 3 hours, it is mine. I am going to perform here. From task 1 till 14, my energy level didn't come down because I was constantly speaking, I was constantly practicing. So I knew that 3 hours continuously, if I'm speaking also, that is fine. But for my luck, it was like a gynae ward prioritization, the labor ward prioritization, everything. They came together, and my third task was a Down syndrome lady. I was completely like, those 20 minutes, you're speaking, and at a point, you get some exhaustion. But again, it's like role play sitting there in front of you with the Downs discussion. Like, no, come on, buck up. You have to communicate. So in this way, my first 2 station itself were like I had to speak more. My examiner was just like asking one sentence, and then they're waiting for my response or my answers to that. So those 20 minutes, it was crucial. Then third station onwards, I started hitting my role players. I was like, okay, they are also going to speak some sentences. So you have to build up that practice, not to get exhausted, and especially towards the exam, start taking mock circuits and start practicing mocks. It could be your friend, your mentors, anybody. So just take some mock circuits. You can even take out the book and start solving, like, one module, one station. 2 minutes you're reading and you start performing. You can do like practice anything, either with your study partner, with a mentor, with the books itself. Anything could be possible. Take off from work or family commitments if required. So it's not like 100% you're concentrating only on studies. If you do have some commitments, then distribute that. It is going to bring down your stress level as well. And practice writing on the notepad the points that you have to speak. Do not write sentences. Write only the key points. This is a name, this is there, okay, endometrial hyperplasia without urticaria, something, or you're just writing out key points, that's it. Not to, you don't want to forget, like for example, any hysteroscopy. So just write hysteroscopy over there. Key points which are there, it should be there in front of your notepad. So you do not forget to mention and forget to discuss that with your role player. And please try to complete your task in 9 minutes. Trust me, with the timer, when you're practicing your task, the speed will come, your modification, everything to the approach to the station, everything changes. Plus, you will be able to give some extra time to the role player. Is there anything else that you want me to address? Please ask that question in the end, because whatever questions or concerns that the role player is supposed to ask you, she'll come up with those questions in the end. When you're about to leave, she will ask, like, doctor, is it possible that I can have a male baby? If you're planning anyway for IVF, why not do gender selection? So towards your like 9.5 minutes, she will pop up with one question. So they can ask you all these things. So it is important that you finish your task by 9 minutes. Please stick to that. Have a perfect approach, be fluent in your sentences, and have a confident beginning, an impressive ending. This is what is going to clear you. And I have cleared my part 3 immediately after my part 2. So I started studying actually when I booked my exam. So then I was like, take out printouts, everything. So my approach was like 6 weeks. And in that 6 weeks, everything about NHS I had to learn. So it is very important that if you're practicing from before, also you people know how the station approaches, everything is fine. If you're a beginner also, yes, there are examples like me who have done it in 6 weeks. So it is very easy exam. Most of it I was doing in my clinical practice. Only thing I wanted to know is how the NHS works. So that was all like I wanted to do as a like backup thing for my approach to the station. That's it. So general information gathering, which I give for all my students, and I expect them to be perfect, is like you're like I'm telling to the role player something. It's like, hello, I'm Dr. Patil, one of the doctors in the antenatal clinic today. So may I confirm your name and date of birth, please? So be fluent in that. Then how do you like me to call you? Because they may ask like Mrs. Jones, or she wants to be called as Anna. So she will tell you how you don't ask her like, can I call you Anna? Let her. She'll like, no, then what will you do? So just ask her like, how may I call you? Or how do you like me to call you? Then you say, she'll tell Kelly or something. So perfect, Kelly, I understand that you're here today to discuss about so and so. Is that correct? She'll tell something, then say that, thank you for confirming this. And if the GP letter is there, then you have to say that. So since we are meeting for the first time, is it okay if I ask you a few questions and know more about you? And then I examine you in presence of chaperone if required with your consent, and run some tests if required also, and discuss the evidence-based management plan, which is acceptable to you. Is that okay with you? How does this sound? So if she is okay with this, she may start this. If not, if there is a BBN station, the approach is completely different. This template is for the OPD kind of an antenatal care or maternal medicine kind of stations. If it's a BBN, the approach is completely different. RCOG expects you to do the BBN first. So there, your voice should be like mellowed down from the beginning itself, because you know that you don't go like, hi, Kelly, or something. We have to mellow down our voice. So you say that, hello, I'm Dr. Patil here, one of the doctors in this clinic today. And can I confirm your name, age, date of birth? And I understand that you had undergone this procedure. So how are you doing now? Is there any pain, bleeding, some discharge? Then she'll be like, okay, doctor, I'm really worried. What is the outcome of the report? I'm just this. I can, you just don't say that, I understand or something. Can just say that, I can see that you're worried, and yes, I'll be discussing your results. The reports are here with me. I confirm your name, age, date of birth. You start, your approach is completely different for BBN station. So we'll be teaching you that this kind of an agenda will hold true for your OPD kind of stations. Okay, so just make sure that whenever you're starting your station, you should know like what kind of management or discussion that it leads to, and accordingly you have to begin. So towards the end also you'll be doing something like giving information leaflet. So tell that in the end, I'll give you some information leaflet about what we discussed today. Fix an appointment with a consultant or specialist if required, and provide you with 24/7 hospital numbers and support groups. Is that okay with you? So quick sentence and covering within few seconds. It is important. Open-ended questions are important part of your part 3. Because if I tell you like, do you have pain? She will tell no. And do you have bleeding? She'll tell no. But if you say like, can you tell me more about your concern? Then she'll tell that, okay, doctor, this thing had happened and I went through this. So she will come up with all the instructions that was given to her as a role player. And she will tell you. So you tell her, can you tell me more about your concern? I'm here today to address them to the best of my capabilities. She will start off explaining everything that she wants to talk to you. So take a detailed history about what complaint she has, an HOPI, and is there anything that you want to add on? So if you have missed something, she will add on to that. About other key points, be very quick, crisp. Can you tell me more about your periods and when did you have your last one? Offer the pregnancy test accordingly. Never forget this. A polycystic ovary who is planning for pregnancy and she has not got menses for 2 months, they have been actively trying for pregnancy. Many of them forget to ask an UPT for them. It is by default they assume that okay, polycystic ovary is there, 2 months amenorrhea. Maybe it is like she has not got. So because they're trying for pregnancy, how can you forget not asking a urine pregnancy test? So this is very important point that whenever you feel that she has skipped a cycle or something, or it's been more than like 3 weeks or plus, and if she feels that there's a possibility, so please offer the pregnancy test accordingly and make sure that she's already with someone and she's sexually active and then you're offering a pregnancy test. If she's like, no doctor, I'm not sexually active, and you're offering a pregnancy test, it shouldn't happen that way. And about obstetric history, have you been pregnant before? Can you tell me more about your pregnancies? So don't ask her how many children do you have. She'll tell I don't have children. But if you ask her how many pregnancy you had, she will tell doctor I had one ectopic, one miscarriage, everything. So your question matters a lot. So just tell her, have you been pregnant before? She'll tell yes, doctor. Can you tell me more about them? And it's all open-ended question. She will tell everything about her pregnancies. Contraception, if she's using, are you using any contraception? If she's using a condom, appreciate that because it prevents against the sexual infections also. And about STI screening, you can just tell it's a part of my duty to assess your sexual health. So, have you been treated for any sexual infection in the past? So, first thing is, are you with someone? Because after that, she'll be sexually active. Are you sexually active? Then, part of my duty is to assess your sexual health. Is that okay? And if I ask a few questions and ask regarding our sexual infections, there could be multiple sexual partners. You can ask, did you ever have more than one sexual partner? You can ask like this because multiple means it could mean like two, four, anything. But did you ever have more than one? If you're asking like this, it will sound a little better. Cervical screening, now it has changed to the HPV. Please do not tell it as a smear test. You have to tell, have you undergone cervical screening? Were they normal? If not, if it is a young age or something, maybe a vaccination you can ask. Medical history, do you visit your GP regularly for any condition? Allergies, if you're allergic to any medication, metals or substance. And if any allergy is there, may I know like what exactly happened? I'll be documenting that in my notes. And surgical history, have you undergone any surgeries on tummy or down below? And were you admitted or treated in the hospital prior for any other problems? So that maybe she had frequent fits or something, she was hospitalized multiple times. So she will come up with those questions and answers. Now, social habits, you don't have to signpost exactly. You can just say a few personal questions or a few questions on your social life choices. Something like, it's not like she's doing some blunder or something by smoking or consuming alcohol, or you're doing some mistake that you're asking a sorry or something. You can just ask few personal questions. May I? And do you smoke? Do you take alcohol? Any recreational drugs? If applicable, especially in case of an abruption, please do not forget the cocaine abuse. She won't tell you until unless you ask. And that's one of the key point, the safety point over there. Now, family history, any family history of concern that you'd like to share? There could be DVT risk, so any history of clots in the legs or lungs, any high pressure, sugars, or if the cancer history that you're going to ask, any history of cancers in the family, if it's some genetic condition for the baby, any condition that or any genetic condition that runs in the family. So simple questions you're asking there. Social history, like what do you do for a living, whom do you live with, how is the support at home, and are you safe and happy with him? So if you just ask, you're ruling out your domestic violence as well. Have you ever felt down, depressed, or anxious in the past few weeks? So it is not like 1 week, 2 weeks, 3 weeks, or 4 weeks. It's something like past few weeks. You can ask like recent past. Blood group, are you aware about your blood group? And if she says like yes, I know, or something, any reservation for transfusion if need arises. This is only if required. You can ask this. So if not, you can skip this point also. So post-operative who may not require a blood transfusion. you can avoid this particular point. But pre-operative, huge fibroid, there are chances of intraoperative blood loss. You are supposed to ask about the blood group and reservation for transfusion if need arises. Placenta previa, yes, definitely. So these kind of questions you can cut short where it is not applicable, or just a quick question in few seconds and finish it off. BMI, you can just ask, are you aware about your weight to height ratio? That's BMI. So if she's on the higher side, if you comment that I'll connect you to dietitian or physiotherapist, then she'll pounce upon you. She's like, what doctor? Everybody is behind my weight, because these RCOG people, they are instructed that whenever a comment is made on the higher BMI, they really get angry. So what you can ask is it of a concern to you? She would say, no, doctor, I'm fine. All my family members are like this. It is genetic. I can't do anything about this. Do not address anything at that point. So I'll tell you about how to deal with all the BMIs, everything in a stepwise pattern in the course. Everything will be taught to you, that you know how you deal in that particular situation. When she finishes everything, you just thank her. Thank you for sharing all information. Is there anything else that you want to add or feel important that you know I might have missed asking you? She will come up with extra points if you have missed. So, doctor, my tubes was not tested. So, what is your opinion? Should I get my tubes also tested? It is like, yes, I was about to come to this point. Don't tell her, you know, you completely forgot or something, but smartly deal with that. Yes, I was about to mention this point, and then you start discussing that point as well. So some things which you might have forgotten to ask and the role player demands, you have to deal with that smartly. Or if you remember at that point, then having said this, so do you have any allergies? So do you have any reservation for transfusion? Because sometimes women may require blood transfusion during this procedure. So if you've forgotten that time and you remember now, smartly deal with that and ask your question. So tell her that your safety is my utmost priority. And based on your information that I've gathered, I'll be discussing all the evidence-based management plans. And if you have the time to properly close your station, you can tell her that, Kelly, I've given you a lot of information today. So keep checking her understanding throughout your station. Every 4 or 5 sentences, am I clear? Any doubts that you have, any questions, anything you want me to repeat? So keep asking and checking her understanding. And I have given you a lot of information. So this is the information leaflet about what we discussed today. I'll be documenting our discussion in the notes, and I'll give you in touch with the support groups as well. And if required, I can arrange another appointment with consultants. Some stations, the consultants are away or something, and you're apologizing and then taking the station forward. So later on, you have to arrange another appointment with the consultant, because basically she has come here to see your consultant. These are the emergency numbers, and if you have any queries, I'm happy to clear them for you. Me and my team of doctors, we're always there to help and support you. So when you have your time, please make sure to tell her that yes, you're always there for your support. She is in the verge of some decision making and she's not yet sure. Just you can tell her that, you know, take your time, like have a word with your partner, your family members, your caregivers, your friends, and get back to us. So if it is depending upon the emergency, like whether next day you're calling her again, next week you're calling her again, it could end the station in this way also. Just be calm, explain your points, and make sure she's understanding everything. And in the end, you have to thank her. I'll be teaching you how to end in each module as well. Different modules have different endings. So if it is an OPD, you just thank your role players. So thank you for your time, and then you can exit. So close the station in a good way, in an effective way. And sometimes you may not be able to finish everything, but still make sure if it is just an OPD, just give a smile. If it's some BBN, please do not smile. So you have to exit your station there. But if it is something, you know, getting up or something and it's an OPD, just say thank you for your time and you can shift to the next one. Physically and mentally. Why? Because the station went well, you are going to perform the next station in a good mood. If the station did not go well, don't carry that thing to your next station, because your burden of or the stress of your previous station should not disturb your next station. Leave everything then and there. When you get up from your chair, or when you're in an online exam, the screen changes. Mentally, physically, everything, you're leaving that station. Trust me on that. you forget the previous station. You go to the next one with a clear, fresh mind. You're ready to receive all the information that is given there within 2 minutes and perform the next task. Your attitude should be your every station should be better than the previous one. If anything goes wrong in one station also, it is still okay because they are going to judge you globally. Yeah, it's like 9 or 10 station you have done really bad, then there is a chance of a negative markings or negative result. But 1 or 2 station here and there, it doesn't affect much. As I told you, people have scored higher percentiles as well, and still they didn't reach the applied clinical knowledge to the mark, but it is still acceptable because they don't expect you to have a great knowledge or something for the part 3. It is one of the essential factors, I do agree, but having backed up with the other domains. So if anything goes wrong, you're not able to complete, but your rest of the station that you have performed is really well. Do not get worried about that station. Leave the station. Next station is important. You have to give your best in the every station that you're performing. Till the last station you're doing, your energy level shouldn't come down. Your enthusiasm, your will to perform it the best, that should never come down. Even the last station should be done with the equal energy that you have performed your first station. This is really important. So let's start the journey. Here I am with my graduation degree. So all of you, I want you to be like seen in this attire, in this photograph. Trust me, it was really a great ceremony. I attended just pre-COVID times, Feb 2020. I got graduated because our ceremony that I could attend. So I went to London and there I attended. And great ceremony. All the dignitaries, everybody, after handing over the degrees, they were waiting outside in 2 lines and they were clapping their hands, and we were made to pass through them, and everybody were cheering and congratulating each other, and all the candidates, they were wishing. It was really a dream come true kind of a thing. So I want all of you to be seen in this, and do share me the photos when you're attending your graduations. And this is Dr. Geetika. She's from Delhi. So I'm from Bangalore, India, and I'm a consultant at corporate hospitals here. And teaching was my passion, so I wanted to continue with that. Dr. Geetika, she's based in Delhi. So she's our another mentor who will be dealing with again few more modules. Dr. Siddesh, so he's a urogynecologist based in Mumbai. So he was a clinical examiner in May exam 2022 as well. And lucky to have him. He'll be dealing with the urogyne modules. And we do have Dr. Rupali. She's NHS based, so she'll be taking regarding the clinical governance points as well. So about the library, I have already spoken. Extensive, exhaustive library collection that we have. There are written templates, voice libraries, and could you please share the screen so that I can see the
And you are not audible.
Hello, am I audible now?
Yes.
Okay, okay, dear. I think there was some device problem. Yeah, so few questions in this group, as in like uh, what exactly is going to be the course, things, and other timings, everything. We'll be discussing that. So the course begins from 18th of August, the early pregnancy module. It will be ending with the Eurogynae, that is on 27th of October. So we'll be placing all these modules. The antenatal care, maternal medicine, gynae module, they'll occur at frequent intervals because there are a lot of topics to be covered. So two sessions will be covering, and one or two modules we have to squeeze in because the time duration that we have. So within 2 months everything we need to cover. So starts from the 18th of August. So we'll be putting up a detailed timetable. We'll be putting up all the tasks that are going to be discussed in the entire course as well. Along with that, we do have other sessions. So what we exactly do in the course. So there are practice books which I keep posting. So all of you have already gone through the groups, and also the recalls, everything, they have been posted. The practice groups are being posted. So we start off with the Lisa. We'll be assigning one task. So when we are assigning a particular task, just Lisa is an important book because it's an RCOG one. You need to go through that, have an approach to that particular task, and submit your voice task as well. We'll be assessing you that how is the fluency, how you're speaking, the tone of the voice, how modulations you're doing, and within the time frame. So I generally advise all my candidates that target it within 9 or 9.5 minutes maximum, because this is how the practice is going to build. So from day one itself, you have to submit your task within that time frame of 9 to 9.5 minutes. So our target is first to cover the Lisa. Next, we'll go with the Justin Conje, the Oxford Get Through Tony, and Richa Saxena, and 50 clinicals. If the time remains, we are going to cover them also. This is about the course Telegram group where only 6 of you are going to discuss, right? And me and Dr. Geetika are going to give the feedbacks for you people. In the warrior groups that we have, constantly we are going to discuss all the recalls that have been posted, how the approach to that particular station, they could change the scenarios a bit, but the gist of the station is going to remain the same. The information or the role play questions may vary, but we'll be telling you regarding how to approach for that particular the station as such. So whatever questions are coming, you'll be prepared for that to answer. So the warriors group constantly will be putting up the recalls, and you need to solve them. There are channels created where the written templates are going to be added up. So if you are not in a mood to record something or just want to scroll up and read some material also, you can do that. Whenever your approach to the module is there, I want you people to go through the that particular module templates, that particular module voice recordings. You have to spend time, listen to them, read them also, because nothing is going to be new. Even my students who presented in the early pregnancy, that was her first ever presentation that she has done in the entire MRCOG journey. Even that was like close to 90%, I would say, because she had done her homework, she had gone through whatever materials that was provided. She knew how to begin that, how to gather information, that what we have taught here, she was practicing that. Plus the approach to that particular station, how it is done, she had been listening to that recordings as well. So she knew what has to be spoken as such. I would say 90%, because still some corrections had to be made, the voice modulation had to be made. So that comes with the practice. And how we are going to practice, the practice books are going to help with that. You have a complete station over there. Read that thing in 2 minutes, jot down your key points. Within like few seconds, you need to know what you're going to focus. So with the practice, this is going to come. And there are my students who had crossed 11 minutes, 12 minutes, but they kept on recording again and again. And finally, they said, Madam, this is the 15th time I recorded, and finally I finished in 9.5 minutes. They have been pouring that much effort. So they have been practicing. They knew how to cut short those sentences also, and even we are helping out. So if I'm listening to your recording, and if I feel that this particular explanation of a BBN, you took a long time, 1 minute, 1.5 minute, entire thing went in just signposting and coming to that particular explanation. How to cut short that, we will also tell that. So that we will be able to judge only when we are listening to you constantly. and that is going to build up your confidence. Any station that comes, you know how to speak. By default, at your spinal level, everything is fixed. So you just have to perform that day, those 3 hours. So at every station, every module, the approach, and how you're going to do the time management, all these things. Even when I take my the course sessions, the live session, I keep a timer. I'm like, see, the timer is running in front of you. You should hurry up. You should know where to cut short your sentences. So there is a timer which is kept. So I stick by that. You have to finish that things, because the next station itself is completely different module. You can't be in the hangover of your previous station. You have to move ahead and then perform the next module. So it's very important. A shift, the transition, everything happens, and we'll be dealing with all these particular modules. So the entire thing that we are going to post now, it is going to be for your 18th of August, the early pregnancy care. Most of your classes are going to be on Thursdays. Few classes could be on Monday or Tuesday, where we need to have some repetitions, or the module is vast, so we have to cover that. Or one module we have to squeeze in because there is a little short of time. So people who are performing for the long course, people, they have 20 live sessions, so they're almost like going to finish their course now, but the practice will continue. So even the live sessions have ended, we are constantly in touch with the Telegram group. So the practice is going to be continuous. And this is the another batch, August B batch. People have requested for this. So till now, all the batches currently, they are all full. So the new batch, it is launched today, because again, candidates requested for another batch for the August. So this is the regular course batch where 15 live sessions are going to be conducted. Beyond this, there is no time or the chart for me to even squeeze in another set of batch of students for a regular course. So this is the last regular course that we are going to run for November 2022, where 15 live sessions are going to be discussed. After that comes my marathon. So all my course candidates will be getting a 50% discount for the marathon course. They can approach, where I will be teaching, I will be performing, I'll be telling all the revision key points in 5 days time, where you'll be solving close to all like 100 plus stations. So that marathon course, all my course students will be getting a benefit as well. So currently this August batch B, this is the last one that I'm offering. So I take only 6 candidates because I want to give a quality teaching, and 6 live stations are going to be discussed in every session. And if any member is absent, I give the next person the chance. So it goes on rotation, understanding basis, that whoever is an absent candidate also, the next person performs. Then next time, if anybody else is also absent, the other candidate performs. So it goes on rotation basis. Otherwise, it's compulsory for all the candidates to perform one station per module in the live sessions. For voice library, any number of stations that you're submitting, we'll give you the feedback for that. So we are assuring that we are checking you on all those points, and definitely me and Dr. Geetika, we are there. So whatever, any doubts, anything that you people have, do get back to us. And I wish you all a happy studying from the team Rayzacademy. It was so nice to have all of you over here, and just briefing about what part 3 is about, and how our course is different. So it's just a limited small groups that we create, but all these course members, they will come together in the warriors group, and all of them are working on the recalls there. So the course Telegram group is for the practice books. The warriors group is going to be purely recalls, irrespective of whichever module live session is happening. And the templates are there just for the revision purpose. The voice recordings and the PDFs have to be covered prior to your session, live session. So before that, make sure you're reading through them. You are listening to those tasks as well, so that you know a proper approach. Plus, in the live session, we'll be giving you all the templates, how to approach. We'll be telling you all the sentences. I'll be teaching you, me and Dr. Geetika, we are teaching you all those, the key points that are a must in that particular station to perform. Okay, all the best, all of you. So any other doubts that the course candidates have? Anything that you want to ask? Or any other doubts? The live session people have joined. So any other doubts that you have regarding part 3, just drop me a message. If you want to know further details about the course also, I'm happy to help you all with that. Any doubts you people have? My course candidates. Schedule will be posted there. So today I'll be posting all the things. Don't worry, Nancy will be taking good care of y'all. So I'll assure you on that. So all the schedule and the topics that we are going to discuss. I do want to post. I'll not post the complete station anytime because you should know the topic what it is, and the station will come with a description everything on that particular live session day. So you will be knowing, okay, this is Down syndrome. You will be knowing this is herpes. You will be knowing, okay, this is a X-ray exposure. So you know what topic is going to be discussed, but the station, everything is going to be like the recall based, whatever the past questions were there or the role players have been asking. So it is going to be similar scenarios, I would say. Then practice everything whatever is there. We give like sufficient half an hour for each station. It's like your 10 minutes of your performance, then the discussion happens, then any other doubts that you people have, so that is going to be cleared. So one station goes almost for half an hour. So limited number of candidates. The advantage is that compulsorily you people are performing. I want that. I don't want you people just to perform, 3 or 4 say, like stations and all, and you don't know in the end. You're just listening to others and you're not speaking. You know what has to be said, but if you tell that sentence in your manner, it could be like heard differently from that particular other person who has performed that task, right? So the more and more the practice books and all you're solving, the recalls that you're solving in the groups also, the more and more we are going to refine you. With every submitted task, we are assessing whether this approach was correct or not, or anything that has to be changed, then definitely we'll be advising on that. Okay. So any other doubts? Okay, dear. So we'll wind up this introductory session. So any other doubts, anything that you have, we'll get back in the course group again. So happy studying, and it's going to be a team effort. I want all of you from day one itself. I want all of you to be like completely active. They were like almost there was a batch in my previous year where even before the course started, the batch was formed like a month before, and we started off with the practice books. They had completed 2 books even before the course had started. They were like everybody was submitting. We give the feedback, they're ready with the next. So constantly all 6 of them, and trust me on that, they were more than equal to 300 plus station they had solved in the group itself, because we constantly kept on solving the books, the recalls, everything. They were like there was nothing that had to be done, and all of them like just cleared with flying colors. So the constant participation is important. We will motivate you. There could be some days where you're not able to submit a task. It is understandable, but whenever you're getting a time, please spare 10 minutes and submit your voice recording. This is what I want from all of you. The dedication, hard work, smart work, your help or support, anything that you are requiring, we are there. So let us start this journey. All the best, and see you all in the course group. Any doubts, anything that you have, please put up in the course group. I'll solve it there. Okay. Thank you so much. Good night, dears. Take care.
Thank you, ma'am. Good night.
Thank you. Take care. Bye bye.
Thank you.